Well, here we are, another podcast. How are you today, Renee?
Hey, I'm doing great. How are you?
Fantastic. Getting ready for spring. And so this is the time of the year that I meticulously go through and make sure I have all my tools ready to go because I know I'm going to be fixing a lot of stuff. And do you know that when you buy tool sets, they skip numbers? So I've been looking all over for a 16 millimeter wrench because, you need all of them. And so I'd like to have full sets of things, and big equipment. You have to have big wrenches and sockets, but you just can't always get the ones you need. And so it's been a challenge. I know you can't
Mm.
relate at all to this discussion whatsoever.
No, but
But
but I can about spring. So we have on our deck, we have birds that have decided they really need to get into the house. And so my sliding glass door looks like something was trying to get in. I mean, and lots of it's toward the bottom. So I thought, well, maybe there's some animal trying to enter our house. Oh, but no, we figure it out this morning. I'm sitting in my chair doing what I always do to kind of get ready. And this thing just keeps pounding in the window, pounding in the window. So birds are trying to fly through the kitchen window, the sliding glass door. So I have dirt from top to bottom with little like messes everywhere. I guess that's a sign of spring, but I wasn't exactly prepared for it because it took us a day or two to be like, what are those marks and how are they getting there? Yep, this morning I figured it all out. So thanks, spring. The birds are
the
back.
challenges of spring, we could do a whole episode on the challenges of spring and how we're going to get through.
And
So
I'm not even on a farm, so I don't understand what could possibly be
I,
happening out there. Sounds like lots of
oh,
challenges. So today we're going to be
absolutely.
talking about these certified community behavioral health centers. And, that's a relatively new concept for people and it's newer to our state. It's been around in some other states a little bit longer, but it's a federal initiative. And today we're going to talk about, what are those? What services are they supposed to provide? How is it really kind of supposed to work? And then how does it sort of fit into the behavioral health system? So what's good about them? How are they supposed to work? And we referenced these last time a little bit in our last podcast saying we were going to do a deeper dive. And today's the day we're going to dive into this. So I'm going to let you kick this off, Jason. So what is a certified community behavioral health center and what are they supposed to be doing?
Yeah, absolutely. And I think it's exciting to have this conversation, right? Because really, this is an initiative, that we see the CCBHCs federally kind of recognizing that the behavioral health system in general has lacked a clear continuum of care. And so, with the beginnings of 988 and crisis, really CCBHCs they represent the effort to get people out of acute care emergency rooms and to that need for acute care. And we're going to talk about acute care in the next couple of episodes because these things all flow together. And I think we have to think about how these are solutions, but no solution is perfect. And so CCBHCs are a set of core services that help basically support that crisis system and the safety net that we need in all of our communities to ensure that everyone can receive the right level of care at the right time and have it be affordable to them. And just me saying those three things, there's a whole lot of stuff to unpack right there, isn't there, Renee?
Yeah. And so we already had community mental health centers or CMHCs. This is going to be a full acronym type of series today, but a CMHC is supposed to be community mental health center. So from what you understand, Jason, what's the big difference between the two? If we've already had this CMHC system for decades, and so now they're moving toward this community behavioral health center. So what's the big differences that you notice kind of between those? What are the differences?
Well, here in the state of Iowa, we have even another complication that helped our system go completely awry. And that was we have separate substance abuse treatment centers. And so, at a minimum in our state, CCBHCs force us to be truly co occurring competent, which means to treat any condition, whether it's a substance use disorder or a mental health condition. And considering how many people have co occurring mental health conditions, that
Right.
only makes sense. And the fact that it's 2024 and we still have separate licensing standards, accreditation
Mm.
standards, it just still blows my mind how that has happened. And so CCBHCs allow a mechanism for all treatment to occur under one roof. And we'll talk a little bit in a minute about some statistics of how we see that promoting better care.
Yeah. So a couple of the things that are supposed to be similar that I can see, right? They're supposed to be available 24 hours a day, 7 days a week. You're supposed to be able to have that crisis component to it. So somebody answers the phone, gets you somewhere. And it may not be a particular location or building that's available all the time, but it's supposed to be available. And then you're supposed to be able to be kind of that comprehensive care, like you're talking about, where they can go to one kind of more of a one-stop shop to get behavioral health support. So you don't have to go to separate places. We keep talking about that for two different assessments. You should be able to go to one place. And then I know they're supposed to kind of have this care coordination. And care coordination is a funny topic to me. And I don't know, we haven't done a deep dive into this, but in our state alone, I mean, just think of how many versions of care coordination, just without even trying, off the top of our head, that we can think of. You know, you have care coordination, and you have navigators, and you have integrated healthcare systems, and you have, you know, case managers, and they name them all different things. And the funny part is, to this day, they still don't work together. So it's still not coordinating anything. It's just individual people with a lot of different titles. And I remember way back in the day when I was a family therapist, we would have those family team meetings, they were called, and you'd bring all the team together in the room, supposed to be only talking about the positives, which was not really helpful when you had people not doing the things they were supposed to, because you're only talking about the positives. Anyway, we'd have all these people brought together that were supposed to be coordinating things that rarely spoke to one another and really didn't know what was going on. And I don't even know that we have those coordinating meetings anymore, but this is supposed to be a way to sort of coordinate care. And I appreciate that. I also know that they've got some required services with CCBHCs. So Jason, you want to run through those? What are those required services that they're supposed to be doing once we get these up and running?
Yeah, absolutely. And I was just going to share with you, Renee, I was in a meeting yesterday and we counted 4 case managers for one person, and
Ooh,
none of them helped to coordinate the care. And so that's current. The system's still grappling with that, right? And so,
yeah,
CCBHCs, those core services are designed then to integrate all of those partners together,
right.
right? And so a component of the CCBHC is to have ownership of that crisis system. So when we think about
Mm,
mobile crisis response,
mhm,
connectivity to law enforcement, connectivity to, emergency departments, especially in rural access hospitals and critical access hospitals. We really see that as the connection point for crisis services. They're to take lead on outpatient mental health and substance use services. So they should
mhm,
be the outpatient clinic of choice. They should have a wide variety of groups and other services.
mhm,
Um, they should focus on person-centered and family-centered treatment planning. So they should be engaging the entire family system. Family and peer supports in the
mhm,
counseling services are
mhm,
very important. And, it's funny, I was talking to someone yesterday and they said, I have a group of parents who would really like to talk about depression, anxiety with their kids, and there's nowhere for me to send them. And I said,
oh,
that's a huge need, right? That would be a great way for support to occur. And that's just not something that's currently available in
mm,
many areas, across our state. I've heard that in other states as well. Targeted case management. So again, that high level coordination, understanding what someone needs and making sure that those connections are made. Outpatient primary care screening and monitoring. So this is where we get in to those social drivers. And so, I think as we look ahead to social drivers of health, thinking about how does behavioral health care interact and coordinate with physical health, and that's a
mhm,
key element of CCBHCs. Psychiatric rehab services, so those services that help people to grow, employment services, think about all the things that people need to be successful in the real world, and then screening, diagnosis, and risk assessments on an ongoing basis. Did I cover them all, Renee?
I think so. I've come up with two questions for you. So, you know, in the community mental health center world, they were supposed to be sort of the safety net services where everybody could get care and, you know, all people. Is that intended in CCBHCs as well, sort of that no eject, no reject, that their safety net? Or will there still be both, as far as you know, community mental health centers for safety net plus CCBHC, or do we know yet?
I think that's a loaded question, Renee. And you set me up to ask me that question. We don't know today. In the state of Iowa, HHS hasn't yet committed fully to this. We
Mm,
know that always follow the money, right? That the funding mechanisms that support CCBHCs are very advantageous to the state to be able to support this. And so certainly I think the vision in my world, the vision should be that we replace CMHCs and the substance use providers with a comprehensive CCBHC that is fully funded, because these programs only work when there's funding to
mhm,
support the services that they
mhm,
do. And our current system is underfunded and
mhm.
doesn't have access to those funds that are necessary to support them to the level they need to be supported, especially in rural areas.
Well, I'm just curious because I don't, if our listeners know, but you and I know that CMHCs, or community mental health centers, have this bump in funding, and they're created separately in the code with this funding mechanism to pay them a little bit more than other providers. And I know that's been changing through the years, so maybe they've sort of leveled that out. But for a long time, there was sort of this funding preferential, if you will, because they took the safety net folks that are the hardest of the hard, that didn't, they couldn't cherry pick their clients, they couldn't take the best of the best, which sometimes happens in in private practice, right? You just pick the kind of people you want to serve, whereas community mental health centers couldn't do that, right? So there was a funding incentive to sort of help, catch them up on those costs and things, and we haven't really seen that funding mechanism created yet for the certified community behavioral health centers. And so it's going to be interesting to see, to your point, tracking the money, where those things go. Another question I'm coming up with, because I'm sure our listeners want to know, but do you think we're going to see primary health care kind of put into these centers? Are we going to see maybe nurses and nurse practitioners to take care of that outpatient primary care screenings? Do you think you could see in your mind a model where even maybe primary health is included in? And I know that's true in some of the different facilities, like we have our free clinics and different things that add components of that. And then there are community mental health centers that have added a physical health component, but it's not consistent. So I didn't know if this is if we see kind of a path, if you will, for primary health to kind of join in the building or be next door, kind of cohabitate. What are your thoughts in that space?
I mean, we see that happening in other states, and we know on the flip side, healthcare, we saw that with federally qualified health centers, that they have to have a behavioral health component embedded as part of the care team. And so I see this as a reverse of that. Absolutely. I think that is the vision, especially in rural areas, to go to one clinic and have all of your needs met just makes sense. It's also more financially viable to have one location, one clinic that can service more people. And I'm not an advocate of bigger is better, but there is a reality to you have to have so much volume to be a sustainable provider of these services. And so let's be realistic about what some of our rural communities can actually support.
Right. Well, and also just thinking about the stigma component, right? If it is a healthcare facility that does healthcare where everything's kind of combined, then you're not feeling necessarily as bad that you're going to the alcohol treatment rehab facility down the street, right? It's a little bit more subtle in that everything is in that space. And then maybe there's a way for you to get the help you need without being called out so much, which in rural communities is everything because everybody knows everybody. This is where I always tell stories. My dad was a counselor, a therapist when I was growing up, and he had his office next door. And we lived in the state of Illinois, and everybody really loved the personalized license plates. And so talk about not really being a great opportunity for confidentiality, right? If so-and-so showed up and I knew their plate, I'm like, oh, hey, Dad, what are you doing counseling so-and-so, right? I mean, we were taught not to really ask, but at the same time, we're like, that's probably really not the way it's supposed to be. Not to mention the work line came into the house that we'd accidentally answer upon occasion. So we had some issues, but I'm just saying, a small town, I mean, right, people would know. And then I just thought my dad knew everybody at the store. Little did I know there were a lot of his clients, right? And so you're thinking back on, that confidentiality. So, I mean, it really made an impact on me because I lived in rural America and I understand what that's about. So just thinking how this might be one step toward, kind of helping reduce that stigma if we're all in healthcare together. So, Jason, I don't think that in the list that you said what was, required by CCBHCs, I don't think that included everything. I think that did a lot of things, but it's only a piece of the system. So what do you see as some of those other pieces? And I know we're talking about right now going through our series on the 30,000 foot view, but there's other pieces that are still going to have to be in existence. I don't think these are going to come in and replace everything in a system. So what are some of the pieces that still need to interact and work together with the CCBHC?
No. Yeah, I mean, there's a ton of things outside of that system that we can recognize and acknowledge that are still necessary, right? So there's lots of specialty care, private providers. When we think about access centers or 23-hour, I think we've talked about that in previous episodes, those 23-hour, safe places for people to be, diversionary type units, crisis residential, residential substance abuse treatment. So there's still lots of levels of care within that continuum that need to happen outside of the walls of a CCBHC. So CCBHCs don't fix everything. You're exactly right. It's one very important piece of the puzzle.
Yeah.
but it's just part of the much larger service continuum that we need to maintain focus on. And what we see so often is our legislators or policymakers, they get focused on one thing and think that's going to fix it all. And unfortunately, we know that doesn't work because that just fixes a little part, and then it puts too much pressure on that little
Mhm.
part, and then the rest of the system collapses around it, and everyone blames it then on the thing that they propped up. And it was like, well, you didn't have your eye on the big picture. And we see that happen over and over again. And that's frustrating. And that's frustrating
Yeah.
for people in the system. It's frustrating for families. And it's frustrating for those policymakers and lawmakers who think they're doing the right thing and then end
Right.
up just messing it up even more.
Well, and to your point, right? CCBHCs are propped up currently and established by federal grants in a lot of cases. That's what helped get them started. There are different states, and we're in a period in our state, and others are too, of competing for ongoing dollars to be a demonstration state for these things. And if the state, though, isn't ready to catch and provide state dollars to sustain it, $2 to $4 million to get it up and running is one thing, but to be able to sustain that ongoing, and if there's not the funding mechanisms, to your point, to continue, that's where you see those big shoots up and down, right? There'll be like brand new facilities that crash because there's this initial push and lots of federal or state dollars go to it, or grants or whatever, and then they don't think about, well, how do we fund this in the out years? And that, as to your point, has been an issue in our state and many others, is that they kind of get it started, everybody gets excited. And then the other thing that I know, and as well, is when you start these new ones, workforce comes from somewhere. We don't just have trees with new employees. And so they take people to these new initiatives from other established entities. And then there's a workforce challenge in the other established entities that have been in place, that have been there a long time. Sometimes you can pay a little bit more because of those federal dollar bumps or the state dollar bumps. And so you attract people to it, leaving people behind that were in those necessary, critical other services, and then they don't have the employees. And then once those monies go back down, then those folks end up letting people go because they were overstaffed. And so there's this workforce kind of shifting that happens because there's just not more of a pool of people every time you create a new program. So one of the things I know I talk about, and I know it frustrates you, is you never see, like, we're going to create this, so let's stop these things to kind of shift toward this. It's always like, let's just add one more thing to the pool, one more thing. Happens in education all the time. You can ask your wife, I'm sure she'd be on board with this. And you just add more and more and more and more. And you don't talk about, well, what are we going to take off our plate so that we can do this? And that's the big concern I have right now for the system, is like, what are they going to say? Let's don't do this anymore so that we can make this the center point of our program. And I don't know that we know that yet here or anywhere else, but I know that you've got data on how this is being impactful and what the CCBHCs are doing. So what are you seeing in some of that data that kind of shows, maybe how they're working differently than CMHCs in the past, the community mental health centers, or how you see this kind of moving? What do you see the impact here?
Yeah, and one of the best places to go, and we'll link it in the show notes, is the National Council on of Mental Well-being does an impact report every year, and that kind of looks at the current CCBHCs that are being subsidized by the federal government and kind of pulls some data. And I think it's really fantastic when we can look at data and say, okay, how is what they do, how they deliver services, how is it substantially different? And how do we measure that? And how do we know if it's working or not? Because I love it when we look at a system and have some actual data that tells us, is it working or not? I think two key things I pulled out of that. There's over 2 million people nationwide being served by CCBHCs today. So
Wow.
we've got a pretty big sample size when we start looking at this data. And and one of the key takeaways, when I looked at that is number one, treating substance use disorders, right? And so we think about medication assisted treatment. MAT
Mm.
is often how that's referred to. And those individuals in CCBHCs are much more likely to receive comprehensive medication treatment along with counseling for substance use disorders at a significantly higher level, right? And so that's also then leading to significantly higher outcomes. So I think that's really important to take away. The other huge takeaway is average wait times are much less at a CCBHC because of the efficiencies they're able to harness in how they're kind of prescribed to put the service array together. And so having all of those services under one roof does create efficiencies. It helps with the staffing issues because you have the right person getting the right care at the right time, not clogging up the system and the wrong level of care at the wrong time. and that it means more people can get through the system. They can serve people more efficiently, which means people get care sooner, which means they don't then get worse while they're waiting to be seen and clog the system up in those crisis level cares or acute care downstream. So I think those are really positive things.
Right. When we talk about crisis, and we'll do more of this when we deep dive into crisis services, and we know that people that don't get like that follow-up help within 60 to 90 days after a crisis, if they're stuck out without ongoing services 60 to 90 days out, that is a really big predictor that they're just going to go right back into the crisis circle. And so you don't have, to your point, a long time to be able to get folks help, especially follow-up help if it's to the point of a crisis. And so for that to be shorter wait times, to get into programming faster, to be able to get something quicker is a really, really important statistic. And if that's what we're already seeing, then that's huge, because it is, one of my soapboxes I know we talk about often is, when you're in crisis or in the emergency room and they hand you the outpatient therapist card and say, call them for a follow-up, and it could be months. And that's just not enough if you're in a crisis in an emergency room or in a crisis center, an access center, and you are in crisis, you need help before the number of months it might take to get into a therapist's office. And the therapist is not necessarily trained in crisis to be able to help those immediate things. You need those to what this is supposed to do, those wraparound services. You might have a medical component of this that you need treatment right away. You might need that targeted case management to help you get, maybe it's an emergency housing situation, maybe it's emergency food situation. So it's really, really good that they're putting this all together, kind of that one-stop shop. And so it's exciting that it's a plan, that it's out there, that it is what we've been talking about for decades. It's really exciting, but it'll be interesting to see how it all comes together and how we pull it off, because we know that that's been challenging. Now, Jason, in our work, we have helped actually set up CCBHCs in our state and have worked with others in multiple locations. So talk to us about what you've seen in that work with CCBHCs and kind of tell some of those stories, if you would, of what's working, what's not.
Yeah, I think it kind of takes us, and I want to kind of keep it at a systems level perspective, because, it's relatively easy to set up a CCBHC, right? Like, I can help someone get through the accreditation standards with the state, assemble the right team it's going to take to provide comprehensive care. I think where our problem lies is the intersections with the other systems, because our state doesn't have the infrastructure. A good CCBHC is going to intersect with the justice system, with 988.
Yes.
With law enforcement, and looking at the sequential intercept model, right? All of those things need to be interactions, and they need to be forced interactions sometimes through policy and legislation. And unfortunately, you just can't stand up a CCBHC and meet all the requirements if the other systems aren't willing to play. Because it simply won't work. And unfortunately, that's what we've seen across the state. They were funded initially. We helped set up a couple of them. One in particular we helped set up. They got the original $2 million, $4 million from the federal government, went for 2 years. The state had no infrastructure and no continuation plan. And then they lost their designation, and they're still operating the same way, but we don't have official designation. We didn't have funding to continue it. And those systems weren't really had to interact. And so without all of the things being in alignment, it really doesn't work. And I hate to be the naysayer, Renee, but that's what has to happen.
Right. And we've seen some big time work in our state anyway on that kind of after the fact, because in one case of one that set themselves up in the state didn't even know they existed or that they were coming. And because it wasn't connected, the federal government is sending grants, the state didn't know people were catching the funds. And so it was a surprise to the state as well. So you can't really hold the state accountable for those when they didn't even know they were coming. But now they're really trying. They've done at least one RFP specifically on this to try to organize the state into population centers that could have CCBHCs, because that's to your point about being volume. There has to be enough people that could utilize the services to set one up. And the other idea then is to also cover an entire state. And in rural, that is complicated because there's lots of miles with not a lot of people. Not so much as like maybe Montana, but still we have some rural parts of Iowa with a lot more cows than we do people. And so you have to think about, how do you set up a system in a way that can thrive in those rural parts where it's a long, long drive to get to any one location. And that's not easy. And to be the provider who may not be getting reimbursed as well as they should, talking them into being the ones to provide in those rural spaces where it costs a lot more to do the service is a tough sell, as it should be. If you're a provider trying to stay in the black and you're like, but it costs 2 or 3 more times in rural to do it because of the windshield time and the fewer people I can see per day to bill for and all of these reasons, it's hard then to tell a provider, hey, you have to do this. And so I know there's been work, at least in our state, of trying to break it into regions. I know the current legislation that's moving forward in our state talking about redesigning districts to put substance and mental health together. That's the other thought process, is let's do it around population centers so that you can have that volume of people to make it work. But these are challenges. So when you're talking about this in rural, we've talked about it more than just our state. In those states where we're talking rural, what are those challenges, Jason, that you've seen about the CCBHC?
Well, I think you hit it on the head that the key word in CCBHC is community. And that means they serve people in the community where they live. And I just yesterday I had another conversation with a provider, and they provide support services in very rural counties. And they have care coordinators that sit in their car for 8 hours a day, driving from person to person to person. They're like, we can't continue to do this.
Right.
And so the alternative is then to move people to group homes in populated areas, because that's funded. Driving and keeping and supporting people in their communities with their family and with their friends isn't funded. And I think that's the disconnect. CCBHCs are designed to deliver services in the community where someone lives and thrives. Without that, and without funding that in rural areas, then we're going back to the days where we're putting people in institutional living. And so we've changed the definition. So it's no longer big institutions. It's groups of 4 people in apartments in more populated areas where they can be served. And so, I think that's the issue we need to be talking about.
Right. And to be fair, it's not just mental health system, right? You also have your aging system,
Right.
where the number of people who want to age in place at home is astronomical, but the amount of workforce to make that happen doesn't even come close to matching just the workforce, let alone the distance and the time and the access to medical care and all the other things. And so it's a situation of challenge for rural America, that any kind of healthcare services are just tougher. And when you think about time versus space and the number of people involved. And so having to figure out how to fund that, or how to make those services get connected to where it can be feasible, is a rough go. And so we're not the only state in this endeavor. Anybody that's got rural like us, or even more so, are struggling. And so it's not only on our location, but it is something that, I see Congress talking about, well, maybe we swung too far on the pendulum, and maybe we should be thinking about congregate settings again. And that's because it just isn't working in the communities. There's just not enough people to support people at home, regardless of their issues of whatever they want. And so,
However, there are innovations on the horizon that it can work. And so
yeah,
I visited a place yesterday where they're using technology in a way that
awesome.
we can't even dream about. And it's actually increased independence and individuals to live alone
That's
in
awesome.
non-congregate care settings. And we're going to talk about that in a future
Great.
podcast, because I was so excited to see how we could use technology in a way that now, after 2 years of implementation, people are living more independently than they ever thought they could. Like, even the care
That's
teams
awesome.
are like, we never thought this person could live by themselves. And with the
Mhm,
technology packages, you can wrap people in, including smartwatches,
mhm.
and all of the other devices for monitoring. Things can happen, amazing things can happen with less staff, right?
That's right.
One staff can monitor and have an app and be in touch with people 24 hours a day from their own home, and serve more people, as opposed to sitting in someone else's living room to support them, and they're just asleep, and there's no reason for that. So just so you know, it's not all doom and gloom.
No, it's not.
There's amazing things that we can do and embrace that are really going to help us in rural areas.
Right. And the CCBHC is just an amazing concept that, if we do it well and do it right, gets us toward that goal. And so it's exciting that it's here. It's exciting that they're talking about all the pieces and bringing mental health and substance use together. And so we're really grateful for that. So today we're going to talk about the recovering politician's self-care policy of the week. And if you guys have listened to me for a long time, I normally talk about boundaries. And when I speak of boundaries, I think of boundaries with myself because I'm usually my biggest offender is me. And so thinking about setting bedtimes and limiting consumption of certain foods and drinks and things like that. But I needed a little reminder this past week that sometimes you need boundaries with other people. I know we know that, but I forget that sometimes. And my health and my mindset are dependent sometimes about the people that are around me that are impacted in my life. And there's a quote out there about you are like the 5 people you spend the most time with, and it's debated if that's really true or not. But the quote that I found that really hit home for me is you teach people how to treat you by what you allow, what you stop, and what you reinforce. Now that hits home. So if I don't want to be treated poorly by certain people, sometimes I may have to change how much time I'm around that person just so that I teach them that that's not okay and they can't treat people in a certain way. And I think there's a lot of times that there's different personalities, and I'm one of them, who feel like that's mean to be mean to people by not maybe responding to them or whatever. But when other people are impacting my health negatively or my mindset negatively or whatever you're trying to do, sometimes you have to sit back and think, do I really need to spend as much time with these people as I have been? And maybe it's a way to set a self-care boundary. So for me, that's a new idea. I don't have a lot of boundaries among other people. I don't have my enemies list like some folks. And so it's kind of fun to sit back and think, maybe I should think about this. But I don't want to teach people to treat me badly, and I don't want to just reinforce that. And so if that's really a thing, which it is, then I need to be thoughtful about setting a boundary. So Jason, have you ever thought about boundaries yourself and things like, what you put up with and what you don't and how it impacts you? Or is that something you haven't really thought about?
No, absolutely. I think as I've grown older, maybe as I've become wiser, I think I've done a better job of taking myself and putting myself in settings where I separate myself from those things that are negative or toxic in my life, and simply do more of the things that give me hope and opportunity, and do the things that I need that fill my
Yeah.
cup. And so, I've learned to better migrate to the places that are best for me over the years. And so I don't do it kind of, outwardly. I just kind of do it through my behavior and where I find myself both physically and emotionally migrating to throughout the days and the weeks and the months, because, we all know those things that aren't good for us. But sometimes we continue to return to those things just because it's known for whatever reason. And so it's hard to change behavior
Yes,
sometimes. But,
it is.
I think it's a very wise quote.
Well, and now you're 1 month into your big O birthday. So of course it's wisdom. I'd
Right.
100% agree. That's what happened. You had the big O
We didn't have
birthday and
to,
got hit over the head
we
with
didn't,
wisdom.
we didn't need to bring that up. I don't know how that's applicable to any of this.
So today we talked about certified community behavioral health centers and the hope that we have for the future. These are really cool opportunities to really start unifying and integrating services at a level that we've been dreaming about for years. It does work along the ASAM guidelines that Jason has talked about in a previous episode. It does bring mental health and substance use together, and it's really exciting to see them being rolled out in our state and in other states across the country. There's more work to be done, of course, and figuring out how to fund it in rural communities and making sure that there's enough volume of people to make them sustainable is going to be critical. But we are hopeful, and we have some opportunities with technology that we're going to talk about in a future podcast about what it could look like and how to use technology to improve our services. And so until next time, thanks, everybody.